Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. All right, everyone, welcome back to another episode. Today I'm with Dr. Waldemar Polido. He's an oral maxillofacial surgeon practicing in Indianapolis, Indiana. He's a full-time academic surgeon. Waldemar, thank you for joining us on the podcast.
Thank you. My pleasure, Dr. Stucki. Grant, it's a big honor to participate in this popular podcast. I was just listening to it before jumping in here with you.
Awesome. Well, good. First question for you is if you could just give us a brief history of your training and your current kind of practice setup.
Yeah. So I am originally from Brazil, a city called Porto Alegre, south of Brazil. So I did dental school there, and then I did my oral surgery residency there too. Then I applied and I got into Parkland, University of Texas, Southwestern in Dallas. So I moved there in 1988, and I stayed there until 1991. And I then went back to Brazil. Then I was a full-time faculty back then. That's 1991 through 93 or 4. Then I got my PhD during that time. And then I transitioned to part-time academic, part-time private practice. Then finally I went into full-time private practice, but always with an academic brain. So I got heavily involved with different lectures and associations. I used to come every year for the AOMS meetings. I got involved with the IAOMS, the International Association. Then I got involved with the AO, not osseointegration, the AO, craniomaxillofacial, but also mainly with the ITI, the International Team for Implantology. So through the ITI and all these travels and connections, I networked with a lot of people, and I got in 2006, a friend of mine moved to Indianapolis to work at IU, and they had an open position in oral surgery, and we started to set up an implant center here. So I applied to the position, and they liked me, they hired me, and then I've been here since. So I've been here almost 10 years now. And I use a full-time professor in maxillofacial surgery.
Oh, very nice. So great to be doing that full time and helping the residents and teaching them. I know you specialize in many different things, and today we wanted to focus kind of on implants. Maybe just generally speaking, what is your overall philosophy on doing implants?
Well, I got lucky since I got started with dental implants, and that was after I came back from Parkland. I always had a very good prosthodontist near me, because since day one that I placed my first implant in private practice, that was 1992, I think, for a mandibular overdenture. Remember back then, it's all Brånemark concepts, and we had to talk a patient into getting an implant. They wanted to do normal dentures. They wanted to do a bridge, and had to explain, well, we have this new thing now called osseointegration. There's a pin of titanium that is screwed to your bone, and you have to wait 4-6 months, and it heals, and then we connect another part, and then we put a prosthesis in. So since day one, and I still teach that to my residents today, if you want to be successful in implants, you have to understand the restorative concepts and the soft tissue concepts, because implantology is a restorative act with a surgical component. The whole goal of putting an implant in is to have teeth. If you don't know where the teeth go, if you don't know the biology of the abutment connection, how soft tissue reacts, and how you want to preserve bone around that implant for longer outcomes, which was always, again, number one thing I learned from Professor Brånemark is we do it for long-term outcomes, not for 3 to 5 years. We do it for 15 years, 20 years. If we go back in time, Brånemark's first publication was only when he already had 15 years of follow-up. So he had to prove that implants, osseointegration actually works. So that always stuck in my brain. Prosthetic-driven implant placement, nice bone and soft tissue management, and long-term follow-ups.
Nice. What are the keys you teach the residents as far as placing an implant or doing an implant that's going to last, 20 plus years?
Yeah. Well, every patient is a bit different, but the concepts are the same. Number one, and they know, they come to me with the X-ray CBCT and I go, who is going to restore? Is it, dental students process, grad process, referral, outside dentist, who is going to restore? Then we have to, do we have a wax up or some sort of template? Nowadays with computers, we do what we call a surgeon's wax up, so we kind of know where the teeth need to go. Full arch may be a bit more difficult than a single tooth. Then once that is decided, and I do a lot of digital planning, then we start looking at bone. And then finally, I go and look at the patient and we discuss the soft tissue aspects. So it's called risk assessment. I got, when I was in Texas, Dr. Epker was a big proponent of systematic approach. So I have a very systematic approach. I was a co-author of a book that we published 2 years ago on risk assessment in implant dentistry. And that is a very step-by-step approach. So look at the patient, look at soft tissue, adjacent teeth, then you get your CBCT, prosthetic space, all those things, aesthetic risk. So we look at soft tissue, then we design our incision. We assess the need for any bone augmentation or not, or soft tissue augmentation. Talk about the flap design, and then have some sort of template. Not all cases are fully guided. Some are, vacuum form made templates. That's fine as long as you have an idea where the teeth needs to go, depth, emergence profile, prosthetic space, and then we go for the surgery. Then it's surgical details, good anesthesia, good sedation, and gentle with tissues, and try to do it as systematically as possible if it's multiple implants, and just get the implant in the right position and get enough bone and soft tissue around it.
When you evaluate a patient with, severe, let's say maxillary atrophy, how do you decide between conventional grafting approaches versus zygomatic implants, quad zygomas, all the different, type of solutions there are?
Well, yeah, that's a question I get a lot. I actually just got invited to speak in a global meeting next year about that topic, but I personally have changed a little bit throughout the years on that approach. And remember, in the start, we did not have zygomatic implants, let's say, or pterygoids. That is in early 90s, right?
Yeah.
Then and we did not trust short implants either. Everything had to be minimum 10 millimeters long. So we would do a lot of grafting. So patient comes into my office, I'm practicing in Brazil, 40-year-old, completely edentulous, moderate atrophy. I always propose the bone graft, bilateral sinus lifts, anterior blocks, ramus or iliac crest. That's what we had back then. And then you wait 4 or 5 months, and then you go in, you put 6 to 8 implants, and you do what now we call an FP1 or an FP2. You have not the classic hybrid all-on-4. Then you fast forward a little bit, and then the classic, now called as ProArch or all-on-4 concept, became proven. I did a systematic review that shows, 4 implants actually work. And the advantage is you tilt distally implants and you don't need to bone graft. But you still have an issue of lip support, vertical dimension, and then you have to start increasing the flange to support the lip where it should go. So if the flange is too big and you want to do it, patient wants it fixed, they cannot clean because there's no space to clean. The patients would come back with problems around the implants. So those I would graft too, to increase the width of the alveolar portion, to reduce the size of the flange, to be able to give them a fixed prosthesis, or they would have to go with an overdenture, right? But then late 90s, Brånemark came with zygomatic implants, and then Ole Jensen and many others, they all Tulazny, and they started with the pterygoids and the tilted. All that to avoid grafting, which is very invasive, more risk, more expense, takes more time. And then finally, now we're in the immediacy world, where everything wants to be done for yesterday, right? Patients want immediacy. So the advantage, so I always look at patients' overall health, patients' age. The younger they are, the more I tend to propose bone grafting. Can I use, the older they are, they don't want to wait, or then unfortunately, we have to deal with financial issues as well, right? And I talk to my residents all the time. As maxillofacial surgeons, we cannot lose the art of bone grafting. Everybody wants to do pterygoids and zygomas nowadays, right? Now the subperiosteals have another option. But how about bone grafting? We are the experts in bone grafting. I still like to do bone grafting. But if the patient comes in and 72 years old and has this severe atrophy. Even grafting, I cannot improve the restorative outcome, which is another, again, concept that I do a lot, is prosthetically driven bone augmentation. The whole point of doing a bone graft is to be able to improve implant position or implant longevity and favor the restorative outcomes. If my bone graft is too large and it's not going to improve anything on the restorative outcome, then I go and I try to do a all-on-4 or zygoma combined with something. Now we have transnasal zygoma pterygoids. That's what I call remote anchorages. So that is kind of how we decide. It's patient condition. That means age, health, systemic conditions, financial options. What kind of restoration can we deliver based on what we have? So, and then we decide, do they want to do it? Can they afford it? Is it worth grafting or not? Or can we go with remote? Now I love short implants too. So I can do some tilting in the front and a short on the back if I have 6 millimeters of bone. If there's nothing, then we have to decide.
Yeah. Let's say you're in a situation where you are thinking pretty much zygomatic implants are the main thing you could do, and this maybe an older patient with severe atrophy. What are some of the pitfalls and different strategies that you try to emphasize to reduce complications with zygomatic?
Yeah. So, I took my first course on zygomatic implants in 1998. I was lucky to scrub in surgery with Professor Brånemark himself. So I had a very big influence from Professor Brånemark back in the day. So I placed my first zygomatic implant in 1999, a few months after I took this course in Belgium. I went from Brazil to Belgium, took the course, came back. And with me took the course Dr. Carlos Aparicio, which is a big name in zygomatic implants, author of multiple books, and the head of the Zaga Center. So back in the day, we were doing the classic Brånemark technique, and I started doing a lot of those as well. Open the sinus, going way palatal, through the sinus, anchoring on the zygoma. And then we found that 3 to 4 years later, that would increase the risk of complications. Number one, sinus problems, to the point we had to actually go in and remove or break the implant or take it out. Soft tissue dehiscences. And then I actually kind of stopped or reduced a lot doing zygomatic implants by early 2000s. And the reason was I was having those complications 3 to 4 years later. And now I had better implants. I had, instead of smooth surface, I had micro reference surfaces. The modern implants that we use nowadays started to pop up in my world in 2002, 3, 4. I could trust now an 8 millimeter implant or a 6 millimeter implant instead of grafting or doing zygomas. But then, Dr. Aparicio and Dr. Bedrosian and all, very experienced ones started to look at what is happening and then classifying the anatomy better. And nowadays, we have a clear definition when the implant needs to actually go through the sinus. So we do minimally invasive osteotomy. Sometimes we go extra sinus. We change the way we do the osteotomy. We change the flap design. We have better implants to be used in the zygoma area. So the main pitfalls I see is actually still thinking that the zygomatic implants should be done the way Brånemark taught us years ago, like 20 years ago. And it's not the case anymore. Each patient comes with a different anatomy. And then we have to customize the osteotomy. We have to customize the soft tissue flap design, improve soft tissue around that implant, try to avoid going through the sinus if we can. And then the second problem that I see is understanding the three-dimensionality of when you have to do one zygoma each side plus something on the anterior region or quad zygomas, because it's not easy to get the 3D positioning of it. So nowadays, of course, with software, and here, because we are a training institution, but if I'm in private practice, I would probably do the same if I am planning a case. Nowadays, it's so cheap and easy to 3D print a maxilla of your patient. Patient walks in, you get CBCT, you export to an STL file, you print it. You buy a printer for $500 and you print it. In an office, it's worth by a better one, of course. And then you practice on that plastic model. So, okay, now I understand. And because static guiding for implants for zygomas are not really a big, not a big user of it, because it's kind of an awkward kind of guide. Dynamic navigation may be actually an interesting dynamic guide or navigation. So I think it's the bone and soft tissue management customizing the osteotomy to obtain maximum zygomatic anchorage and good AP distribution and good prosthetic emergency, managing soft tissue, and then understanding the three-dimensionality when you have to achieve good AP distribution. Because I've seen quad zygomas where the two implants are too close to each other, so you're not really helping much.
Yeah.
And then how do you combine that? And then, of course, you have a good prosthetic team that understands that too. Nowadays, we have multiple options with different angled abutments, and you can improve the outcomes. You have options as spleening all the implants with a CAD-CAM bar. So the restorative portion needs to understand that biomechanics of it too, so you improve long-term outcomes.
Nice. When you're teaching residents and fellows zygomatic implants, what concepts do you kind of emphasize most early on when they're first learning these implants?
Well, the number one is proper diagnosis and patient selection. Is this patient a good candidate for that? So that's number one. So you assess not only that maxilla, but you assess the entire patient, of course, right? Then as you assess the maxilla, and I use that in every other slide that I have, which is where are the teeth? Where do the teeth need to be? And how we correlate that with the existing bone. So we do dual scan. Patient walks in with a good set of dentures. We do it ourselves. We just stick some radiopaque markers, get the patient on a CBCT machine. So now I am looking at bone, but I know where the teeth are or need to go. How far are we from it, right?
Yeah.
Then I put it on a computer and I start playing around with implant. I just put two implants in, two zygomas, and now we play three-dimensionally on the software about it. And that's when we decide what to do. I may, like I said, 3D print a maxilla. I only do that once the surgery is confirmed. If it's not confirmed, unless I'm training the residents on something, but and then we look at soft tissue. Where are we doing the incision? Nowadays, I do it way more palatal because I want that thick soft tissue to be around the implants at the end. I may do a buccal fat pad release and wrap it around the implants. I may do a little bit of a DBBM plus collagen bone graft around the implant neck. I may use a flat design of implant on the coronal portion so I have less implant protruding. Then we look at those details, surgical details, and then we finally go to surgery. And usually we do it under sedation. Sometimes if we get approval, we do it under general anesthesia because that's easier to teach the residents on how to do it. I usually do one and then they do it, but the key is to preserve as much bone as we can. We already do not have a lot of bone, so why remove more bone? And try to get the maximum anchorage with the ideal AP spread of the implants. And hopefully, if all that works, you can immediately load the implants.
Yeah, it's good to hear. And I mean, you mentioned you use guides and CBCT planning. I mean, are there any situations where you would still freehand, or is it always guided, or how does that work for you?
Always digital planning, always CBCT. But zygomatic implants, to be honest, we do not do it guided. It's basically freehand with a template. I have a duplicate of the denture in the OR, acrylic, transparent, very easy, cheap to do. And then I just carve a big trough on the palatal portion. So I have the palate, I have the teeth, and there's a big opening behind the teeth. So I go to the OR, I just slide that thing in, so I know where my emerged profile is. And then I kind of score my incision, take it out, open the flap. And then we, based on the previous planning, and we may or may not have that 3D printed maxilla in front of us on the OR table. Then I have a pencil, literally a number 2 pencil. And then I just mark on bone where I want the entry point on the alveolar portion. So there's 4 points: the entry point on the alveolar portion, the exit point on the alveolar portion, the entry point on the zygoma, and the exit point on the zygoma. So ideally, you want to have all those 4 points well defined. And then depending on the Zyga classification, the curvature between the zygomatic bone and the lateral maxillary wall, we may go through the sinus if it is a flat Zyga 0 classification, or we go off the sinus if it is like a Zyga 2 or 3, where there's a big curve between the alveolar portion and the zygoma. And then we decide how are we going to do this osteotomy. So we use maybe a round drill, maybe a different drill to go from top to bottom. So we create a little channel, preserving more bone. not always going through the sinus. If it is a big Zyga 4, if you go through the sinus, your implant is like mid-palatal, too far palatal. So you need to bring in more buccal. To bring in more buccal, you have to go off the sinus, engage on the zygoma. So defining the entry and exit points, very important. We basically free-handed with some prosthetic emergence, so I kind of know where that is. At the end, when I'm finally torquing the implant, I can put a pin inside my implant and rotate it until I have a good alignment between all the implants. So that helps for the final, spins. And always checking where the tip of your zygomatic implant is exiting on the zygoma, because you want to make sure it's not on the orbit, it's not behind the zygoma, it's not in the, I can feel it, but the residents that have never done it or have done it just a couple, I want them to see it. So we do larger flaps when we're starting with the residents. As they progress and as we do more, we can do smaller flaps and feel where things are and you have better control. But ideally, you want to see where that tip of the zygoma is exiting, and then you measure. And of course, anybody that does zygomas knows that you cannot have just one measurement on the table. You need to have a bunch of, because even the computer is not perfect. You do a little angle and that changes your length from 45 to 42.5 or 47. So you need to have 2 or 3 lengths per implant you're placing available.
Okay. And then when you mentioned that there are occasions where you do graft, around it, what are those situations and where exactly are you grafting on that implant?
Yeah. So imagine an implant, the coronal portion of the implant is exposed because I'm going lateral to the alveolar bone, and I want to increase at least the soft tissue thickness. So if I have good soft tissue and my incision was more palatal when I suture, if I'm doing immediate loading, I even can place the abutment or a healing abutment, so I leave it exposed. But if we are not sure if the stability is good enough or the prosthetic team is not ready to immediately load it, then I can close. Still, I put a short healing abutment in. Makes it easier to find it later when I go reopening. If I just put a cover screw, it's hard to go find that thing later when I want to open. So I just put a short healing button. And then I may graft that coronal portion of that implant. I like to use a material which is demineralized bovine bone plus collagen, which is no granules. It's easier to adapt and cover. Some people use allograft fibers. That's fine. You may use PRF if you have it available around those things. I may or may not, if I want more soft tissue, it's right in front of us. You get the buccal fat pad, kind of release it, and you suture around the implant neck, although it resorbs almost completely, but it helps to increase the thickness of that tissue. Those are the instances where you may reinforce or enlarge that bone and soft tissue around the coronal portion. Because if you do that, the seal will be better, and that will lead to better, potentially long-term outcomes. It's not for stability of the implant. It's mainly to avoid any sinus openings and to increase the tissue around the neck. And with that, you reduce potential problems for contamination or periimplantitis, if you want to call it that.
Got it. Okay. And any special post-op things you do, prescriptions, ways you follow up with the patient?
Nothing crazy different. We prescribe antibiotics, usually like some augmented is good enough, anything that gets the sinus. And then of course we do use corticoids during surgery. Pain control. I'm not a big fan of opioids, but some patients are more than others, so we do that. We discharge them same day. We don't keep them in-house. If we're doing it in the hospital, if we're doing it in the clinic, they go home. And then the follow-up depends on immediate loading or not. So in our school, sometimes I do have the pros residents with me too. So we put the abutments in, and they do what we call a chair-side pickup while the patient is waking up from sedation. And then we put a cap on the abutments. Patient goes home. And then 2 to 3 days later, they go back to the pros clinic, and then they just remove the caps that protect the abutment and just deliver the prosthesis and screw retain it, adjust the occlusion. And then I usually see that patient 6 to 8 days after surgery to check if the incisions are fine and if the prosthesis is not putting pressure on my graft. So there's a lot of teaching for the pros residents to trim the prosthesis in a way that the patient will have swelling and it's going to go against the prosthesis. So I need to have that space, and the trimming and all the contour of the denture has to be well done. So I work a lot. We in our implant center, I actually spend time with both oral surgeon and pros residents in the same clinic. So they both the pros guys learn the surgical needs, and the surgery residents learn the prosthetic needs. So that's where the things go. That's basically it. I'm not a big fan of a chlorhexidine post-op, so I don't use it. I use a herbal thing. I don't want to mention commercial names, but it's available. A thing that is more gentle to the initial soft tissue healing for 7 to 10 days, and that's basically it. Sinus precautions, of course, and still, even if they are immediately loaded, they stay in a soft diet for a month or two, but they have their teeth. Patients like it when we do it.
Yeah, that's really nice that you're able to work with the pros residents as well and kind of train them and kind of control that whole experience for the patient.
Yeah.
As far as like, potential complications, I would assume infection is one of the bigger ones, but what are some of the complications you could potentially see, and how do you deal with those?
Yeah. Well, everybody has complications. If they are saying they don't have complications, they're either lying or not doing enough cases. But the number one complication we see is soft tissue dehiscence. Either the coronal portion of the implant gets exposed, or if you're doing an extra sinus implant and the flange, for some reason we didn't control enough, the mid portion of that implant gets exposed. That is an easy one to fix, because then we just do a soft tissue graft and increase that area and tell them to trim the denture. It may happen also during healing, as the patient, let's say we did not immediately load, and the patient is wearing a conventional denture with some soft liner, and that's putting pressure on that body of the zygomatic implant that is in between. So then it shows not a true infection, but there is dehiscence. So we have to trim the denture and fix that. Sometimes we do get some sinus infections immediate post-op, so we have to, put them on antibiotics, sinus decongestants, and hope it heals. It does not compromise osseointegration. Occasionally, we have an implant that does not integrate, so it's moving. So we have to take it out, let it heal, put a new one. In the last 10 years, I remember one case where we thought it was great. We always get a post-op x-ray, and then the tip of the implant was dangerously close to the orbit. So I decided, let's remove that implant, because if we load it and it moves, it's going to go in the orbit. So we took it out, let it heal, and then we just put a pterygoid in to help. It was a quite difficult quad zygoma. We only get like crazy difficult case because nobody wants to touch those. They send it to the school. But that's basically it. In the past, I had worse complications when doing always through the sinus, like acute sinus infections, and to the point where I had to work with an ENT, go through the nose. You do a transnasal opening of the ostium to drain that better through the nose, to release the pressure from the sinus. That is a classic technique that was published by even the Brånemark Center years ago. It's been a long time since I had to do one of those. And I actually had cases in the past where I had to remove the implant that was osseointegrated, because the patient said, I'm done with the sinus problems. I've done this ENT thing. I've done everything. But it's not an easy task to remove an osseointegrated zygomatic implant. You have to open it. And I had, remember in my career, I had one case that I left the tip in and I just cut the implant off. Then we did a sinus graft later to put a normal implant in.
Okay.
So those things can happen. The more you do it, the more experience you get. Hopefully the risks decrease, but every now and then you may get one of those, either a sinus infection or a soft tissue dehiscence, or lose an implant.
Got it. Okay. Yeah, I was going to ask you, how often do you see patients, with like that patient you're describing, who have chronic sinus issues, pain, things like that? Is that pretty rare, or is that?
It's been less and less because of these techniques that we talked about, that I learned with Professor Aparicio and Ed Bedrosian, and we keep tweaking and being more conservative on the sinus area and on the soft tissue management. So we see less and less. I've been here at IU for 10 years, and I did not have yet any coming back with sinus problems. We lost an implant. We had one that we had to remove, that one close to the orbit. We had soft tissue dehiscences, but not the sinus problem. If I fast back in my previous work in Brazil, I remember, like, let's say I put an implant in I don't know, 1999 or 2000, and then by 2003 or 4, I remember having a streak of patients I needed to remove with big sinus problems. And that's when I stopped kind of doing it. And I presented actually that thing at the Amos meeting, I don't know, 2001, I guess, or two. That statistic, but it's decreasing the number of patients that we run into big sinus problems now.
For younger surgeons who maybe didn't get much exposure to this in residency, where do you recommend they start if they want to get into this type of implant dentistry?
Yeah. So there are several opportunities for surgeons, maxillofacial surgeons, to learn how to think and plan zygomatic implants. For a start, AUMS always during the annual meeting have an implant workshop, a zygomatic implant workshop. This year we had Professor Carlos Aparicio from Spain, which for me is one of the best teachers in this topic, very experienced. The guy that puts a lot of effort and thinking behind it. He's 72 years old, still actively teaching and practicing. So I think we had two great lectures this year, the hands-on workshop with Aparicio and the Edmund Rosen's lecture at the Amos annual meeting. So that's always a sold-out event during the Amos. But then you do have courses in the United States, several ones. I have no preference. I'm just trying to remember. Dr. Picos runs one. Dr. Nygaard in New York runs another one. Picos in Florida. Jay Nygaard in New York runs a complication symposium on that. I think Vichy Bruman does a course too where he's in Arizona. I think in California, Baclay and others, they have a course like that too. We're planning one here at IU. And then internationally, there are, if you look at let's say the Zaga Centers network, there are courses everywhere. I have a friend from the West went to Brazil, to São Paulo, because that's one of the few ones that actually they treat patients. So you spend 5 days in Brazil, in São Paulo. It's a very good course. It's not what I call a safari kind of course. Very well organized, English-speaking teachers. It's for international audience. And they pre-select the patients, and you actually get to scrub in and put a zygomatic implant in a patient.
Nice.
And then they follow up, they get restored. There's a whole team teaching. In Europe, they have zygomatic implant courses too. In Barcelona, Spain is the main one, but they have it in France. They have it if you just go online, you see good courses in the US. Most here in the US are plastic hands-on or cadaver workshops. Internationally, you may find some that actually treat patients versus just, again, cadaver workshops. So I am a bit partial to the ones that the Zaga Center runs worldwide, because I am a part of that. I am an academic partner. I do a lot of publications with them. But I think it's a very well-structured, didactically and scientific evidence, very sound course that it's a start, and then you just have to keep doing more to learn. It's a continuous learning process.
Yeah, that's helpful to kind of hear who's doing it and what opportunities there are. That's really great.
Yeah.
I mean, looking ahead 10 to 15 years, where do you see zygomatic implants kind of fitting into the broader landscape of implant dentistry?
Yeah, that's a really good question, because to be honest, I don't know. But now we are seeing too, I think we will see still a growth on it. And I reflect on it a lot for my lectures and publications. We saw when it got launched, a big growth and then a decrease. And now it's coming back again because of the immediacy concept, and because something that I personally don't like, and sometimes it's done too much, which is extraction of relatively healthy teeth that could be treated periodontally and prosthetically, and is just proposed to take all the teeth out and put 4-6 implants in and do a hybrid prosthesis and removing bone with it. So when you get a 4-year-old that has, 8-10 teeth in the maxilla, 18 teeth in the mandible, and they can still be treated with good dentistry, perio, pros, restorative, and a few implants here and there, and you take all the teeth out, and you take 8 millimeters, 6 millimeters, a centimeter of bone out to hide the transition and put a hybrid prosthesis in, you're speeding atrophy. So when these patients are, and they lost the teeth or are losing because of poor dentistry or not being motivated to clean. So why do we think they're going to be motivated to clean this new denture? Looks cool, but for 3-4 years, and then it fails. So when those implants fail, and unfortunately, the number one indication now for zygomatic implants, and this we call graftless remote anchorage, is failed treatments, previously failed implants that take away all the bone with it. And then you're left with nothing. Challenging soft tissue, challenging bone, hard to graft. Patients are wear off of, they're emotionally tired. They're financially with no money because they spend 40 grand on something that didn't work. And then we have to be mindful. I just recently wrote 2 papers on this concept of full arch treatment with Baclay from California. And then one was actually systematic review. And it's like, hey, let's, at the end of the day, we're still our dentists. Let's try to keep teeth and preserve bone and do minor grafting if we can, and if we take the teeth out, do socket preservation, bridge preservation, then put the implants there to achieve long-term outcomes. So I think because of all this thing going around, we will still see a little bit of growth on zygomatic implants. When those start to fail, that'll be a problem. But also at the same time, now we have the rebirth of the subperiosteal implants, the CAD-CAM subperiosteal custom-made implants, titanium, for severe atrophies. Maybe this is the now state-of-the-art, not zygomatic implants anymore. In Europe, if you go to Germany, Switzerland, Spain, or France, most surgeons are actually now not doing zygomas in favor of the subperiosteal implant. You CAD-CAM it, you just see like a plate where the best bone is. You open a flap, you slide that thing in. It's relatively new. There's no long-term outcomes on it. Seems very promising, especially for the mandible, very atrophic mandible. So I don't know. I do not have a lot of experience on it, but the more I read and talk to those doing it, I am starting to think of using for the extreme severe atrophies in the maxilla instead of zygoma. So maybe that will take a little bit of the patients that we only had pterygoid zygomas to place. We will now think the subperiosteals. But so I don't know. I think it's a very good technique. Like Professor Brånemark always said, this is not your go-to everyday technique. It's a very good tool for a very specific patient in very well-trained surgical hands and restorative hands. So it's always going to be there as an option, I think. It's the more you do it, the more you understand. I actually like it a lot. But it's not for every patient. To be honest, I look at a patient. Can I sneak in a 6-8 millimeter long implant on the back and a 3.3 in the front? I'll have the same kind of danger. Why am I dealing with pterygoids, transnasal, zygomas if I do not have to?
Yeah, and that's good to hear different options, the indications for doing it, and also just the concept that you brought up that the most common indication for zygomatic implants is previously failed implants and full arch that may or may not have should have been done, and like the concept of getting the patient early and doing good hygiene and saving teeth. I mean, that's where we really want to start with these patients. So
yeah, doing smaller grade. If you think if there was a tooth, there was a socket. If the tooth has to be extracted for whatever reason, you can always do ridge preservation. You can do we call serial extractions. You preserve. You think, where are my best implants going to go? Oh, molar, canine, premolar. All right, take those teeth out, do ridge preservation, keep the remaining teeth healthy for 4 or 5 months. Then you go in, put the implants on those sockets you grafted. Then you go in and extract the remaining teeth. At the end of the day, the patient will have an FP1, FP2 on nice, good alveolar bone, and that's it. And then, of course, there's a lot of other implications like lab fees and prosthetic fees and immediacy concept. But if the patient understands the investment, it gives them time to transition from having teeth to now having a implants support the restoration, they learn how to take care of it, it's a good investment. It's like you go buy a $40,000, $60,000 car and you don't ever take it to maintenance or clean it. And then in 5 years, that car has to be trashed because it's worth nothing.
Yeah. Good point. Well, this has been helpful to talk about your experience with these complicated atrophic cases and your philosophies around that. I appreciate you sharing some of this. If we have listeners that have further questions, would you be okay if I put your contact information in the show notes?
Yeah, sure. You can share my Instagram account or by even my email. That's okay.
Okay. Yeah, that'd be fine.
The Instagram is I think it's at Waldemar Polido. So you can share that on your videos and that's
Awesome.
fine.
Okay.
I'll be happy to talk.
Terrific. We end every podcast with a few rapid fire questions. So
Sure.
they're all easy. First one is, what's the best book you've read in the past year?
The best book I read in the past year is called, well, I read a lot. So one is All Physicians Lead, which is a book by this guy that is a physician and was trained at West Point Academy. And he talks about how all physicians can lead in different spots from a resident leadership point of view to a director, main CFO, or a big hospital. It's a really good book for those involved in the medical area. All Physicians Lead. And if you give me a minute, I can get the author's name. The book's just behind me here. But I also read Peter Frampton's. I'm a big music fan, so I read Peter Frampton's biography. So I like that one too.
Oh, very nice. The lead. Is this by Leon Moores? It looks like maybe.
Yeah, it's I don't. Yeah, you added this video, right? So I'm facing the other way. It's upstairs. I don't have it here, but I can. It's called All Physicians Lead. It's a really good book. By
Next question is, what oral surgery thing do you do in your life that helps you with your daily oral surgery skills?
Drumming.
Oh yeah?
I play drums.
Nice.
I play drums. I have a drum set at home. I started some 5 years ago, and I love it. And that not only takes my stress away, I can hit on those things all day, but it helps with memory. Every time you play music, you have to understand what is that song, what comes next, how the song plays. It helps with improvisation skills because sometimes I just go off the song. And it helps with my coordination. I have to move both feet, my hands, my arms, and I have to follow that beat. And that for me, drumming is my thing that I do a lot. I do play tennis too, but I'm coming from injuries, so I am not playing a lot of tennis, but I am playing a lot of drums.
Awesome. Yeah, I used to have a drum set too. It's so fun to play the drums.
Yeah.
How about, what forceps do you use to extract tooth number 14?
I use a 150. Oh, the 14 is 14 is the first molar. I use either a 150 or I use what they call like a maxillary crown horn. But to be honest, most of the time, if I have to take a 14 out, the question is there an immediate implant going in or not? Because if it is, I will section that tooth in 3 pieces: mesial buccal, distal buccal, palatal, and then I'll use a number 3 luxator, very thin, a little thicker than a periotome, and I will use just any 150 forceps and take one root at a time, preserve that socket, and then put an implant in or just graft it. So if I'm teaching my dental students, I still teach dental students half day a week, and I do the lectures. You need to preserve bone. So ideally, to take a first molar out, you get a burr, you section it, take it in 3 pieces, a lot easier.
Yeah. When you do those molar implants, are you like what size implant, like as far as the width? Are they pretty wide or?
Usually they will be a 4.5 or 5 diameter, not too wide. I'm not a big fan of wide implants. For me, wide implants are rescue implants. So usually on a first molar, 4.5, if there is enough bone between the roots, you can sneak in a 4.5. I do have a preference for a design called the tissue level implant because the wider neck of that implant, wider than the body, helps that implant to stay. So I do not use a bone level kind of implant because if I keep torquing it, it can just keep going and never stops. It's a tissue level, the head is a bit wider and I can just put it a bit deeper. And that helps to stop the implant and achieve good stability and still has a good immersive profile.
Nice. Okay. How about what's the best movie or TV series you've watched in the past year?
TV series, Landman on
Okay.
Paramount Plus. Landman is very good. I still watch it at season 2. But I like to watch a lot of different things. But Landman was the best TV series. Movie, let me think. I did like that Formula One movie with Brad Pitt. That was a good movie, action kind of thing.
Yep.
Uh,
That's a good one.
and then I think there was another one. I forget the name of the movie, but I'm thinking of it's kind of a drama kind of thing that I watch it. And then the TV series Adolescence was pretty good too. A bit dark, but that was makes you think if you have kids.
Nice. Okay. And then last question is, what's your favorite quote? Do you have a quote and you repeat to
Yes. Let me just think about, because sometimes my brain goes in Portuguese and back. But it's you know, the TV series Ted Lasso. This guy comes and
Yes.
says from Walt Whitman, "Be curious, not judgmental."
Okay, I like that.
Be curious,
Yes.
because if people do not really know who you are and they judge you, it is, why not ask first,
Hmm.
why are you doing this, or why are you behaving like that, instead of just go, judging. Be
Yep.
curious, not judgmental. That's one of my favorites, and probably that's my favorite because it fits anywhere.
That's awesome. Oh, sorry, one more question. I assume you have kids. What's your best parenting tip for a young father who's trying to
uh
raise kids?
Hard, because my kids are all different ages, but I have three. um be patient.
Yeah.
Listen, listen, be patient, and communicate. That's good parenting. Like old school parenting doesn't work anymore for these kids.
Yeah.
You have to listen to them, be patient, and try to find the best way to communicate.
Mhm.
So each one of mine, they have a different way to communicate and behave. I have a 25-year-old daughter finishing medical school. I have to talk to her in a different way. 20-year-olds, little bit different conversation, little different style. Then now I have a 10-year-old, which is a completely different ballgame, but now I'm more experienced, so I merge everything into that. So
Yeah,
the overall thing is listen to them, communicate the best you can, and be patient, because they are not you. They're not going to do things you want them to do. They will do whatever they want, provided you guide them. That's okay.
sure. That's a good tip. I like that. That's helpful. I have 6 kids, so I'm always looking for good parenting.
Yeah, that's well. I grew up in a family of 7,
Oh,
so
wow.
I'm used to it, and that's a good thing. At the end, when they all grow up, and like now we're all 7 brothers and sisters, we get along well. So it's when we get all together, it's fun.
That's
But
awesome.
my parents went through hell.
Yeah, I'm sure. All right. Well, Valdemar, thank you for taking the time to talk to us today. That's been really helpful. And
Thank you.
appreciate all you're doing and the educating you're doing there in Indiana. That's awesome.
All right, thank you, and I hope to see you around in one of these meetings. And if you need me again for another topic like the orthognathic stuff, we can talk that, or we can talk drumming. Bring your your drum skills, and we can just talk that.
That sounds good.
All right.
Thank you so much.
Have a good weekend. Happy holidays. Thank you. Let me know when it goes in air so I can follow it.
Yeah, I'll let you know. Thank you so
All
much.
right. Bye bye.
Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayoralsurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstucki@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and have been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.